Okay, hello guys, and welcome to our respiratory system. That is chapter 22. And today we're going to be talking about how your respiratory system is able to manage the aeration, how to aerate the lung and how to bring in oxygen and how to remove carbon dioxide, how to bring in oxygen and how to remove carbon dioxide from the lung. Oxygen is the essence of life. We need oxygen for oxidative phosphorylation. We need oxygen for aerobic respiration. That's why they call aerobic, because there's oxygen. And we don't need carbon dioxide because carbon dioxide is going to be turned into what? Into carbonic acid. Be very careful. Remember that. Carbon dioxide in your blood is going to be converted into carbonic acid. So the more carbon dioxide you have in your blood, the more carbonic acid, and the more carbonic acid you have, the more acidosis you're going to get. So remember in the beginning of the course, we said we need everything to be locked into homeostasis. We don't need hyper something or hypo something. We don't need hyperthermia or hypothermia. We don't need hypertension or hypotension. We need the eutension. Also, we don't need acidosis when the pH is too low, and we don't need alkalosis when the pH is too high. We don't want either of that. We want homeostatic range. So if you have too much carbon dioxide building up, that's going to lead to acidosis. So today we're going to be learning about how we bring in air into the lungs and how we get air outside of the lungs. You must also remember that gas is a fluid, the same way blood is a fluid. We discussed last week that fluids are both liquid and gas. Fluids, people say lighter fluid. People say, this aerosol fluid and, the flammable fluids, the gasoline fluids. So these fluids are not solid, but they are either gas or liquid. Now, if they're either gas or liquid, they have to obey the physics. And the physics says a fluid is never moving from point A to point B unless what? Pressure. Unless pressure, one word. Unless, yeah, it has to do with pressure, but what is it? Unless the pressure at point A is higher than the pressure at point B, then it's moving. If you push me here in point A, I'm going to move to point B because the pressure at A, when you push somebody, you put pressure on point A, then they're going to fall into point B. Same thing. So now if air is going to go into my lungs, that means air moved from the atmosphere into my lungs. That's when I'm inspiring, inspiration. But when I'm expiring, air is moving out from my lungs to the atmosphere. Well, that's bidirectional movement. So that tells you what? That tells you when there's inspiration, pressure was highest where? In the atmosphere, then the lungs. And when you're exhaling, pressure was highest where? In the lungs, then the atmosphere. So that point is very important. Now we're going to learn the dynamics. So how does that happen? You see, in the heart, we learn that the blood moves from the ventricle to the aorta, from the aorta into the systemic circulation, into the tissues. So from the pump to the tissue through what kind of pressure? Hydrostatic pressure. Through hydrostatic pressure, pumping pressure. But the lung is not a pump. The lung does not rely on hydrostatic pressure, nor does the lung rely on colloid osmotic pressure. You don't have a solution there. Air is not a solution. So how does it move? It moves by putting pressure in relationship to volume. So your diaphragm, your nervous system, your brain pushes down your diaphragm. When it pushes down the diaphragm, it makes the volume of your respiratory system bigger or smaller. When you're taking a deep breath, what happens to the diaphragm when it moves down? Does it make your thoracic and your intercostal muscles moving out? Does that make the overall room in your respiratory system, the volume, bigger, or does it make it smaller? Bigger. Makes it bigger. So the law, yeah. So Boyle's law says at a constant temperature, meaning temperature is not changing. So where is that? That's homeostatic temperature. Remember we discussed that. We said we don't have, not right now, you don't have hyperthermia. You don't have hypothermia. You have euthermia. You have a constant temperature. So now Boyle's law is going to work for us. Meaning that if the temperature is constant, then your volume and pressure are going to be the opposite. They're going to be enemies. If your temperature is constant, if the volume is big, pressure is little, small. If the pressure is big, the volume is small. So now let's look at what happens when you take a deep breath in. When you take a deep breath in, taking in a deep breath, air is going to go in the lungs. So the volume of my lungs got big or small. When air going in, the volume of my lungs get big or small. When air going in, the volume of my lung got bigger or smaller? It got very big. So when the law says if the temperature is constant, the volume is going to be opposite of pressure. If my volume of the respiratory system is big, that means my pressure is going to be small. And when the pressure inside is small, that means outside is more, so air is going to move in. So we control pressure by changing the volume. Now, when you want to expire, when you want to get the air out, what do? You push, you relax. So inspiration is the problem. Inspiration is pulling the diaphragm down. But when you want to expire, it's like an elastic recoil. So your diaphragm moves smoothly, recoils back up. When it moves back up, what does it do to the volume? When your diaphragm that was all the way down, when you took a deep breath, now when it's relaxing, it went all the way up. What does it do to the volume? Increase or decrease? It's going to decrease. When it decreases the volume, what happens to the pressure? Increase. So when the pressure is too high in my lung, more than the atmosphere, what happens to the air? It goes out. Now you see how it works. No pump here is your diaphragm. Not just the diaphragm. The diaphragm is controlling the rectangle from up to the bottom. It's controlling the vertical diameter. But your rib cage too is controlling the horizontal. So your diaphragm moves down and your intercostal muscles pull out your chest. So the transverse, the barrel, like a barrel, your chest is like a big barrel. It's gonna get really wide. When your rib cage gets really wide, that makes the volume really big. Diaphragm moving down, making it even more bigger. The volume is huge, pressure is really low, air goes in. If you want to exhale, the diaphragm moves back up and the intercostal muscles compress your chest inwardly, so that makes the volume really small and air goes out. Yeah.
So are the muscles moving on their own, or is it the lungs pressing against it?
So the muscle receive sensory. They receive motor action potentials. The same way, so the diaphragm is a muscle too. So who did we say is moving the diaphragm in and recoils? In. Who's moving the diaphragm? The nervous system. We said the nervous system. Your nervous system is sending electric stimulation from the brain, making the diaphragm move down. and it also sending electrical impulses, making your intercostal muscles. Muscles are excitable tissue. So they get electrical stimulation and they move out.
So all this, so the muscles in the rib, diaphragm, the lungs, are all working at the same time, they're all kind of connected, but like.
The lung is not with them. The lung is not moving with them. The lung is responding to them moving. So remember, we said you make the pressure in the lung small, air goes. The lung is like a balloon. You put air in it, you remove air from it. It's like a chamber. The balloon is not moving. It is you who's putting air in it or getting air out. How is air moving in and out? Your brain is doing that by making your autonomic nervous system stretch out the rib cage and move down your diaphragm. Then the lungs respond by getting air in. So air moves in response to the diaphragm. We will see more about that.
They were doing it.
Yeah, it looks like that. But the lung is, like when you see an apple fall off the tree. The apple is not, it didn't walk in there. It's the gravity that's pulling it down. So now the lungs inflate. They look like they do inflate and deflate, but they're not the actual ones moving. They are responding to air going in and air going out. Just like the jar model. Let me show you the jar model that we had. So this jar model is very important. This jar model jar model. Excuse me a minute. My jar model. Oh no. Yeah, maybe I don't have it, but these people are gonna do it for us.
Car insurance costs you a month, $80, $120, nope, right, $38 a month. So there's a comparison shopping site.
This bell chart here represents
See?
the rib cage and the opening here to be the trachea, and those bags there represent the lungs, with the space between the balloon and this plastic being the pleural cavity. In us, the pleural cavity is filled with pleural fluid, but here it's air. This rubber band and this rubber sheet at the bottom represents the diaphragm. The real organism, the rib cage expands when you inhale. Above here, we're just going to drive the platform. So when I depress the diaphragm, I can
You see, that's the exhale.
by pulling down. See that those balloons fill up. When I relax that diaphragm, the balloons fill up. Right, diaphragm,
You see what's happening? So when you pull down,
relax that.
your brain is going to send impulses to your diaphragm. When it pulls down, air moves in the lungs. When you relax it, air gets pushed out. Plus, there's one more thing that's not shown here. You see this glass here? This glass in this jar model is not moving. But in your respiratory system, that's your rib cage. That's moving too. So just like when you pull down the diaphragm, these guys are moving out too. So the overall space is getting, volume is getting much, much bigger. So when the volume gets bigger, pressure in the balloons, pressure in the lungs gets smaller, so air moves in. The opposite. When you leave, and remember the point that the problem is inspiration, stretching things out. But expiration, everything is gonna be coiled softly. Everything is gonna return back spontaneously. It's like a yo-yo. You know the yo-yo is gonna recoil back to normal and air is gonna go out. That point is very important. So you see, we're gauging the pressure and thereby the movement of air based on the volume, That concept clear? Yes, this is very important. Okay. Now, we said that breathing is, the most important thing, the first breath of a newborn baby and the last and the last gasp of somebody who's dying, and all the bodily processes require ATP, but ATP is being synthesized where? Where in the cell do we get ATP? Yeah, in the mitochondria. What's the name of the process that harvests ATP for us? Oxidative phosphorylation. This respiration is called aerobic respiration or anaerobic respiration. That's aerobic respiration. So all the bodily processes use ATP. The respiratory system, now we need to look at the structure and the function of the respiratory system. The structure of the respiratory system is that there is an upper respiratory tract and a lower respiratory tract. The upper respiratory tract extends from your nasal cavity, the nares, the vestibules, the concus, the turbinates, and then you move back to the pharynx. So the pharynx itself is divided into three places. The oral pharynx, that's behind your oral cavity. The nasopharynx, that's behind your nasal cavity. And the laryngopharynx, that is behind your larynx. So first you have your nasal cavity, then you have your oral cavity, then you have your larynx, and then you have the trachea. At the trachea, the upper respiratory tract ends. Then you have the lower respiratory tract, which begins right after the trachea, which is the bronchioles, primary, secondary, tertiary bronchioles. Then you have the alveoli, these sacs, these balloons that are actually participating in the gas exchange. So you must remember upper respiratory tract versus lower respiratory tract. That's why you get an upper respiratory tract infection and a lower respiratory tract infection. Upper respiratory tract infection occurs from your nasal, oral cavity, all the way to the trachea. And then lower respiratory tract starts from below the trachea all the way down to the alveoli. So these are tubes that, remember, respiratory system is not just about getting oxygen in, it's also about getting carbon dioxide out. And you will see in diseases like emphysema, you will see that these patients have an obstructive disease. Obstructive is very counterintuitive. Students think that obstructive means there's an occlusion, an obstruction to air in. No, air is going in, no problem. Is air going out? That's the problem. That's obstructive disease. When you hear COPD, when you hear COPD, chronic obstructive pulmonary disease. So what's the obstruction? There's no, if you have COPD, it doesn't mean you can't get air in. Oh, air goes in, no problem. It's getting it out. That's the problem. Why? Because these alveolar sacs have lost the elastic recoil. So they can get filled, but once they get all stretched out, they do not relax. So you get all the way the air in. But remember, breathing is 2 steps, inspiration and expiration. So when the air goes in, you got enough oxygen, you're getting Uber food coming in, but you cannot throw the garbage out. That's exactly COPD. You keep ordering food in, you keep ordering takeout, but no garbage for you. You can't throw out the garbage, so everything just keep dumped in, and that's why they always have this hypercapnia. Hypercapnia is carbon dioxide, increased amount of increased amount of garbage. And what did we say carbon dioxide leads to? Acidosis, very good, acidosis. So they always have acidosis.
And that's those to the pH amount.
Yeah, because remember, we said if you have too much carbon dioxide, you can't get rid of it. What is carbon dioxide going to be turned into? Carbonic acid, not carboxylic acid. Carboxylic acid, that's the terminal of the amino acid, is carbonic acid. And also remember, never say that we don't want any carbon dioxide in our blood. We need to get all of it out. That's not true. We need a level, eucapnia. We don't need hypercapnia, too much carbon dioxide, and we don't need too little carbon dioxide either. We want a moderate amount. That's why if you do hyperventilation, you get all the carbon dioxide out, you're gonna faint. Why? Because you got out too much. Remember, this course is all about homeostasis. Homeostasis does not mean you remove 100%. You don't want to heat up to 100 degrees Celsius, and you don't want to be freezing cold. You want to be at the proper temperature, 25 degrees Celsius. And also, you want to make sure that the same thing is for acidosis. You don't want too much acid, but you do need acid. You don't want too much basic, and you do need base. You need the right amount. You don't want too much oxygen. You don't want too little oxygen. You don't want too much carbon dioxide. You don't want too little carbon dioxide. And you must remember, we're not getting 100% air in, and we're not getting 100% carbon dioxide out either. We just need the right balance of all of these chemicals. Okay. So we talked about that. We said that we talked about this, that the respiratory system is responsible for the gas exchange. So oxygen coming in, carbon dioxide getting out. Also, the respiration is important for communication, for articulation, for phonation. That sound that you make is completely coming from your larynx. And we just said that the pharynx and the larynx are part of who? Your respiratory system. These pharynx are the vocal cord. The larynx are the vocal cords. They get the vibrations like the guitar, and then they start moving, and then you make the sound. And you articulate with your lips, with your tongue, with your palate. Some letters will never come out if something is wrong with your nose. That's why when you have a bunged up, stuffy nose, you talk like this. So your voice changes really badly. If you're some problem in your tongue, some words you cannot say them. So you see some people sometimes when they speak, lisp or something like that. Yeah. Some of them even become singers. Do you know say singer with a lisp? Yeah, there was an American Idol singer. It was funny. Anyways, olfaction. So you need the smell. What's the most important thing about the smell? Is to warn you from danger. So if you cannot smell nitric oxide, you're gonna be hanging around and breathing nitric oxide till you die. But this noxious insult, like, let me get out of there. It's a warning. Your olfactory system was made for your survival. And also for survival, and also it's very important for your nutrition, because you smell where the animals smell where the prey, so they can go chase it and then eat it. And also your smell is important for your reproduction. That's why this whole industry with perfume is making a lot of money, because somebody you don't like them, they put perfume, you will like them. You will like them. This is biology. So your respiratory system is very important. In addition to that, we talked about acid-base balance. That one, those are the two most important, two most obvious. 1 and 4, gas exchange and acidosis alkalosis balance. Those two in the middle, people don't really pay attention to them, but they actually exist. We said that we need communication, phonation, and articulation. Be able to articulate the words. And olfaction for survival and for reproduction. Okay. Yeah, you have to smell good. You have to spend a lot of money buying really nice perfume, because it's really gonna take you far. It's gonna change a lot when the people social image, when the people have like the social image and your personal image. It's very important. People don't pay attention to that, but it's actually really important. And also we said that there are multiple functions to our respiratory system. In addition to that, you have blood pressure regulation. So one of the most important axes you're going to learn about, even in pharmacology, even in clinicals, is the RAS, RAAS, renin, angiotensin, aldosterone axis. This one you really need to know. So we're going to go over it in the lab today. So the renin, angiotensin, aldosterone axis begins with a stimulus. We began the course saying that we need to maintain homeostasis, but in order to maintain homeostasis, you have to have the ability to detect that something went wrong. If you are insensitive, you don't have sensory receptors, you will never know something is wrong, and it's going to keep exacerbating. So, yes.
It's needed. Like, are the sensors messed up?
I cannot hear you.
So that are insulated, like on the vent, are those sensors messed up?
Even for what?
Like on a vent.
On a fence?
On a vent, it's been on the like a breathing tube.
Yeah.
If people yeah, what about?
Are those sensors messed up, but it's still work out?
Are they conscious?
You're asking the patient.
Yeah, because you can feel a breathing tube and being conscious, and you can feel a breathing tube and being unconscious.
So if they're unconscious, that's.
Of course not. If you are unconscious, what is anesthesia? And unconsciousness is complete loss of sensation. Imagine they do a surgery on you and you're conscious. You gotta be feeling the pain, and you gotta be feeling the touch, you gotta be feeling temperature, you gotta be feeling everything. But if you are unconscious, you'll not be feeling that. So this here is, we do have receptors in the blood vessels to taste the blood. It's too much carbon dioxide, it's too little carbon dioxide. It's too much oxygen, it's too little oxygen. Like they taste the soup. They taste your blood like they tasting the soup. And they feed back to your brain. Say, oh, this person got too much carbon dioxide, is gonna be turned into carbonic acid. We're gonna have acidosis. Brain, you gotta do something about it. So the brain now is gonna hyperventilate to shunt off all of this carbon dioxide. So you see, they are the ones who control your brain. Or the opposite. You're the type of a person that you have now too much oxygen and you send out, you hyperventilate. They used to have a challenge on TikTok like that. People would even die. So they, yeah, you remember something like that. This was, oh, I think you remember Vine? Yeah, it was on a Vine. So they used to have a chalet and they blow off too much air. And what happens now is that all the air comes out. And now you become, loss of carbon dioxide. And now there's too little carbon dioxide and the pH goes up too high. You have alkalosis now. So now then they will tell the brain, now depress the breathing. So you're gonna breathe more slowly. So instead of having 100 breaths per minute, now you're gonna have 30 breaths per minute, and that's gonna lead to carbon dioxide to build up in your blood. So the point is, there's gotta be sensation, and the sensation is gonna feed back to a processing center in the brain, and then after that, you're gonna have this regulation. So the angiotensin is called the renin, RAS, RAAS. You're gonna see that a lot. RAS, RAAS, renin, angiotensin, aldosterone system. This RAS system is responsible for restoring blood pressure. So if the blood pressure now is too high, renin is going to be secreted from the kidneys. Then renin is going to be converting angiotensinogen into angiotensin 1. Then angiotensin 1 is going to go up in the lungs, and in your lung, you're going to find ACE or ACE. There's a whole class of medications known as ACE inhibitors. These ACE inhibitors, they don't let ACE work. And when they don't let ACE work, ACE is not going to do its job. What's the job of ACE? From the name, angiotensin converting enzyme. ACE, and A for angiotensin, C for converting, E for enzyme. Angiotensin converting enzyme. This angiotensin converting enzyme is going to convert angiotensin 1 into angiotensin 2. When you now have angiotensin 2, your blood pressure is going to drop. And that's going to restore your hypertension. Is that clear?
What's the S?
Hmm?
Oh, no, what's the S stand for, right?
System. Oh, you're gonna see it a lot. This, I promise you, this will not be the last time you see RAS. You're gonna see it. You're gonna see it on all the other chapters. In the kidney, you're gonna see it. Today, you'll see it. Last chapter 2, when we did the heart, when we did blood circulation, we talked about it. The renin, angiotensin, aldosterone system. We're gonna keep talking about it, and you're gonna get it because it's very important. Many medications rely on it. Any other questions? You had your hand up? Yeah, because remember the whole problem was the blood pressure was up. So now the feedback is it's like when you're speeding, you press the brake. You don't press more gas, you press the brake. And if you're going too slow, you don't press the brake even more, you press the gas. The ACE, no. So the ACE converting, the angiotensin converting enzyme is gonna inhibit angiotensin from being converted into angiotensin 2 and bringing the blood pressure down. So now we're gonna give it to the patients in order to, so it is given when we have low blood pressure. Sorry, we have low blood pressure. We have low blood pressure. We do the ACE, and then ACE is going to bring up our blood pressure. Are we clear?
Yeah, so angiotensin 2 brings blood pressure down.
Yes.
So ACE inhibitor doesn't want that to happen.
Yeah. Yeah, that's the medication. So we're gonna look at it in a slide now. Yeah, so it begins by a problem when the blood pressure is too high. When the blood pressure is too high, and ACE is going to bring it down. Okay, so we're gonna look at that. Don't worry.
ACE brings it down.
Okay. Okay, let me show you the slide. It's gonna make more sense when we go over the slide. Let's see if this even has a slide. Okay, we're gonna get back to ACE. this. This is a very important concept, but let's just finish our classification of the respiratory system. We said that respiratory system is divided to how many tracts? Two tracts. Upper, it begins from where to where?
The trachea.
Excellent. And then
Alveoli.
alveoli. It's okay. That's the lower respiratory tract. Well, what kind of classification was that? That was just anatomical. So this school now has how many floors? Two. This the other, we don't do nothing down there. So we just say third floor and fourth, right? Third and fourth. Third and fourth is just the anatomical structure. Third floor, fourth floor. Does anybody know what happens in third floor? Does anybody know what happens in fourth floor? We do because we go here. But people from outside being told that in this school, there's a school on the third and fourth floor. Do they know where HR is? Do they know where the classrooms are? Same thing. You can say I have an upper respiratory tract and I have a lower respiratory tract. What's happening there? So now you need a second classification known as functional, physiological classification. So now we're going to talk about the functional classification of the school. Third floor is the classrooms. Some classrooms are still up on the fourth floor. And third floor is where the president office and HR. And on the second floor, there's like the faculty offices. So now we divided it into functions. So now I know the structure and the function. Before saying upper respiratory tract, URI, URT, and lower respiratory tract, LRT. That is an example of that's an example of structure. Where am I? If a penny lodge inside my respiratory system, where is the penny? Is it on the upper respiratory tract or is it on the lower respiratory tract? But I don't know what's happening. Now we're gonna know. So now we divide our respiratory system into conducting zone. So everything, your nose, your oral cavity, your pharynx. We said the pharynx is divided into what? Oral pharynx, so you begin from the top. Nasopharynx, oral pharynx, and laryngopharynx. Then you have the trachea. Then you have the bronchioles. Then you have the alveoli. So everything up to the bronchioles is a conducting system. It's just conducting air. Only the alveoli is the respiratory zone. So everything else is the conducting zone. Everything in the conducting zone is just passing air to the most important part of your respiratory system, your alveoli. Your alveoli are golden. They are the most important part of your respiratory system. So everybody, this point is really, really important. Everybody from your nose up into your bronchioles has one job, is to pass air to who? Your alveoli. Once your alveoli get the air, then they give oxygen to the hemoglobin in the blood, and they take carbon dioxide from the hemoglobin, and then they remove the carbon dioxide to the conducting system, and in exhalation, air goes out. So you have a conducting zone, and the conducting zone passes the air in, and you have a respiratory zone where the gas exchange happens. This is really important. Now, you must also understand this conducting zone is not going to take air the same way it is and deliver it to the alveoli. If you take a sample of air going in your nose and air inside your alveoli, is it going to be the same? What changed? Excellent. There's going to be filtration. The dust is going to be removed. All of your nasal tubes are pasted. You know the mouse glue? The mouth that when the mouse step on the glue trap is gonna get trapped. All of this mucus is like glue. So if, you know air is very nasty. is full of bacteria, full of pollutants. So all the mucus is like, yeah, this is why when you go is because you caught a lot of mice, you caught a lot of bacteria, you caught a lot of microbes, you caught a lot of insects, you caught a lot of dander, you caught a lot of sand, and all of that now is gonna be thrown out. So you're right, there's gonna be a lot of filtration. What about humidification? Do we air condition the air that's coming into our alveoli? Of course, because air outside may be too cold, snowing outside. You don't breathe because it's too cold outside. Of course, you breathe. Too hot outside. You don't breathe because the temperature's too hot. So you respiratory system, in addition to filtering out the air, it also conditions, humidifies the air. So that when it reaches the alveoli, it doesn't hurt the alveoli. Imagine the alveoli dealing with cold air, it's gonna get injured. Imagine the alveoli dealing with too hot air, it's gonna get injured. So the alveoli gets the proper air after it passes through. So it's unfair that we call this the conducting zone, because it's not only conducting, it's conducting, filtering, humidifying, and all of these protective things. Is that clear? Okay, so now you also must understand that we conduct the air in and your immune system. So this mucus is not just glue. There's a lot of macrophages and a lot of immune police cells there because some of the microbes are too wicked to be caught by the mucus. They invade the mucus. So now you have an immune system fighting them back and removing them. Clear? So you have the conducting zone and you have your respiratory zone. The respiratory zone is the alveoli, and these are the gas exchange region. We talk about the upper respiratory tract. They say nose through larynx. Some books consider it the larynx. Some books go down to because you have the nasal, oral, pharynx, larynx, trachea. Some books include trachea, some books include larynx. Really, tomato. If you get in, they will never put in a choice, where does the upper respiratory tract end? Larynx, trachea. You'll never see both. So whatever the one that you see, if it stops at the larynx, that's the answer. If it's the trachea, then you choose the trachea. Okay? So let's now inspect our nasal cavity. So first of all, you begin very big, then you zoom in, you zoom in, you zoom in. So we look at the forest, then we look into the trees. You have two entry sites, your nose and your mouth. That's how important air is. Also for digestive system. You don't just eat with your mouth. When you get really old and you cannot swallow due to dementia, now what do they put inside your nose? The feeding tube. Of course, feeding tube goes to your nose. And sometimes, the prisoners that do the food, they boycott food. They say we're not gonna eat until you improve our conditions. You know what I mean? So now they're gonna die, and they're gonna be in trouble. The department is gonna be in trouble. So they force them. They put a new nasal tube. They put a feeding tube in their nose, and they squeeze food in their stomach through their nose. Because remember, it's the same passage from your nose going down to the esophagus right here. So they empty the food. So they fill their stomach by food anyways. So now they don't die. So if you look at the respiratory system, it has two inlet, nasal cavity and an oral cavity. Nasal cavity, you have the vestibules and the nares. There's a lot of hair and cilia like the mop, because that filters out. The mop is filtering out all the dust that's coming in. There's a lot of mucus. These concha and turbinates, they call them turbinates because the air is like a turbine moving inside them and getting purified. Then air goes into the trachea and then goes into after the trachea, it separates. in the carinas, then we go into the bronchus, and then we finally end into the lungs. Please remember, we talked about the heart. The heart has two capsules around it. Remember, we had a visceral pleura and we had a parietal pleura. And between them is the pleural cavity. And it was full of what? Serous fluid. Now the same thing. The lungs have a parietal pleura and the lung have a visceral pleura. We said functions of the nose: warm, cleans, humidifies air, detect the odors. And you know, if you look at the nose, it's also part of your face. It's also, you know, one of the distinctive features. And you see that the nose has root, bridges, and apex, and nares, and this is the septum. So you see that this is all made up of what? Cartilage. That's not muscle. That is not bone. These are cartilages. The vestibule begins on the nasal cavity, is a small dilated chamber just inside the nostrils. They're lined with stratified squamous epithelium, and the vibrissae are stiff hairs that block insects and debris from entering the nose. Those cilia-like hairs, they're like doing a power stroke, recovery stroke, and they're like a mop in a bathroom mop, you know, mopping all of the dirty stuff outside. Okay, the chamber behind the vestibule. So the chamber behind the vestibule is occupied by threefold, known as the concha. The superior, middle, and inferior concha, also known as the turbinates. Why did we say we call them turbinates? Because air becomes turbulent inside them, and that's how it gets purified. Air gets spinning inside the turbinates. So there you go. That's, you see your vestibule, and that is these are your conchas. That's your superior concha or turbinate, middle concha, turbinate. You see, we said that we call the conchas the turbinates. You have the superior concha, middle concha, and the inferior concha. Yeah, that's all the filtration happens there. Then you have your, between the conchas, you have your meatus, superior meatus, inferior meatus, and middle meatus. And you have your tonsils. These are your lymphoid organs that participate in filtration of lymph. And that's how you identify them on the cadaver. You see your concha, superior, middle, inferior. And then you have your superior meatus, middle meatus, and inferior meatus. And you must also remember that the septum is divided into a perpendicular plate and a septal cartilage and this vomer cartilage. And the pharynx is a very important anatomical landmark. It's divided into three regions. The top floor is nasopharynx. Then the middle one is, because it's right next to the oral cavity, we call it oropharynx. And then right below the oropharynx, we have the laryngopharynx. The pharynx, or the throat, is a muscular funnel extending about 5 inches from the concha to the larynx. From the concha to the larynx. These are the muscular funnels. So the three regions, we have your nasopharynx, your oropharynx, and the laryngopharynx. The nasopharynx is going to pass only air, and it is anatomically aligned with pseudostratified epithelium, while the oropharynx and laryngopharynx pass the air, and they don't have columnar. They have stratified squamous epithelium. It's really important to know that. They have, so the oropharynx and laryngopharynx are made up of stratified squamous epithelium, while the nasopharynx is made up of pseudostratified columnar epithelium. The larynx or the voice box, you would have cartilaginous chambers about 4 centimeters long, and the functions are primarily to keep food and drink out of the airway. That is known as the epiglottis, and they have a role in phonation. That is the production of the sound, phonation and articulation. Now, the epiglottis is very important. It's a flap, is a valve that ensures that food does not lodge into your trachea. It does happen every once in a while, but it doesn't happen as frequently as it should because of the existence of this epiglottis. So the epiglottis is a flap of tissue that guards the superior opening of the larynx, and at rest it stands almost vertically, and during the swallowing, the extrinsic muscles of the larynx that pull the larynx upward. So you see, this is cartilage. This is very important laryngeal cartilage, and there's corniculate cartilage. The interior wall has 2 folds on each side, vestibular folds and vocal cords. The vestibular fold is located superiorly. It plays no role in speech, and the vocal cords are located inferiorly. They produce sound when the air passes between them. The glottis is the vocal cord and the openings between them. So the glottis ensure that they cover. So the epiglottis is different from the glottis. The epiglottis ensure that food does not lodge inside your trachea. But the glottis, they protect the vocal cords, not the trachea. The vocal cords and the opening between them. So you see, this is the glottis, represents the vocal cords and tissue that is between them. So the trachea is also known as the windpipe. So there are very important anatomical structures that have a common name and an anatomical name. You remember last time when you took AMP1 that there was a scapula. What is the scapula known as? The shoulder blade. Excellent. You also studied the patella. What is the patella known as? The kneecap. Very good. And you also studied the calvarium. What is the calvarium known as? Skull cap. Very good. And you also studied the clavicles. Clavicles are known as the collarbones. And now the trachea is known as the windpipe. It's a rigid tube about 12 centimeters long, and it is in front of the esophagus. So that's why it takes tricky training. So if you want to enter the intubation tube, you ensure that it goes into the trachea. You don't put air in the stomach, in the esophagus. You put the air inside the trachea. Yeah, they use a camera. They use a camera. Back in the day, they just needed, it's a skill that you get taught how to just, it's not that hard, but with practice, it becomes easy. But no, they definitely use a camera. So the trachea is made up of cartilage, C-shaped cartilage. It's not an O shape, it's a C shape. And between each ring is a C-shaped ring, C-shaped ring. Those C-shaped rings, between them, what do you find? Smooth muscle. And that's how asthma happens. You see, between those cartilages, between the cartilages, you have your smooth muscle epithelium. The smooth muscle, sometimes, the smooth muscle is contractile tissue. It's contracted. You know blood vessels are made up of smooth muscle, they contract, right? They contract. So now the people with asthma, they have a problem where the smooth muscle between the C, so you have C-shaped cartilage, C-shaped cartilage, C-shaped cartilage, C-shaped cartilage in the trachea. Between each C shape, you have a layer of smooth muscle. Sometimes this smooth muscle spasm and very tight, so it prevents the outflow of air. So that's the problem with asthma. So we need to relax. We need to relax by administering the albuterol. This albuterol relax the smooth muscle in the bronchioles and between the tracheal C-rings, and that causes dilation of the airway. Because they're tubes at the end of the day. You don't only have blood vessel tubes that need to be relaxed. You also have airway. The airway, what's the difference between an airway and a blood vessel? The tissue. What kind of tissue make it up? The smooth muscle is endothelial cell in the blood vessel. But a blood vessel is all smooth muscle. But the airway is a mix. It's cartilage with smooth muscle between its here. Okay? Okay, the inner lining of the trachea is the ciliated pseudostratified columnar epithelium. It is composed mainly of mucus-secreting cells. These are ciliated cells and stem cells. There's a mucociliary escalator mechanism for removing the debris, and the mucus traps or inhaled particles. And we said that this upward beating of the cilia. The cilia are hair-like structures. So we already discussed that in our nasal cavity, oral cavity, our respiratory tubes, we have the glue, we have the mucus to trap, to glue up all of the bad debris, insect, microbe. But don't forget, we don't only have mucus, we also have immune cells. And in addition to immune cells, what also do we have? We have the hair mob, the cilia. What else do we have? The macrophages. Yeah, these are the immune cells. Good, the macrophages. And we also have the cilia, There's right and left main bronchi, and the trachea forks at the level of the sternal angle known as the carina. Remember, we mentioned the carina? The carina is the point where your trachea is going to bifurcate to each lung. So, you have two lungs. In the beginning, you have one big tube, the trachea. Then when you get to the point, you're going to split into two lines. One line is going to go into the right lung. The other one is going to go into the left lung. That point is the carina. So that's the internal medial ridge in the lowermost tracheal cartilage. It directs the airflow. You see where my mouse is? It directs the airflow to the right and the left lungs. So the thyroid cartilage and the cricoid cartilage. So you have the larynx, and you see here, you see the C-ring, the C-ring cartilage, C-ring cartilage, C-ring cartilage, and between the C-ring cartilage, what is between that? Smooth muscles. Very good. And you see that you see the C-ring here? That is the C ring. That is the C ring. And in the middle, what do you have here? That's the trachealis muscle. See the tracheal, that's the tracheal epithelium. And in tracheostomy is to make a temporary opening in the neck in order to place a tube into a person's windpipe. Okay? And the tube is inserted through a cut in the neck below the vocal cords. There you go. You see the tracheostomy? And we enter it into so we make a slit and we enter the breathing tube. Now, this is the lung. So if you look at the lungs, the right and the left lung, they are not mirror images. If you put them both, they don't look alike. Why is that? Because the right lung has three lobes, an upper lobe, a middle lobe, and a lower lobe. How are they separated? By fissures. You have a horizontal fissure and an oblique fissure. A horizontal fissure and an oblique fissure. This horizontal fissure is at the top. So if you look at both lungs, both have an oblique fissure. You see? Both of them have an oblique fissure. Both of them have an oblique fissure. And the right lung, in addition to having this oblique fissure, they have a horizontal fissure. So here you see you have a superior lobe and then you have an inferior lobe. Now look at the apex. The apex is the most pointy part of the lung. So the apex is the top part of the lung. Unlike the heart has a bottom apex. So the heart is like an inverted pyramid, but the lung is like a cylinder shaped pyramid that has a pointy top. The heart has a pointy bottom. It has an apex. Sometimes they call it apex beat. So there's like a beating, and then they put the stethoscope, and then they feel the you feel the striking of the heart to the wall So the hilum is a slit through which the lung receives the main bronchus, the blood vessels, the lymphatics, as well as the nerves. So there's a cross section through the thoracic cavity. That shows you now a transverse look, like a CT scan. We said the lung has a base. This is actually, there's something very important you need to know also. Now this lung, we're gonna do this in the lab also. The lung has a pointy apex and a base at the bottom. Now, do you think blood vessels stretch all over the lung? The blood vessels, let's say that, for example, you see this door here, let's assume that this door is one of the lungs. And let's assume that this door at the top has an apex, a pointy top, and a base at the bottom. Do you think this whole area of the lung has blood vessels on it? No, it's only in the bottom. That's how it is. All the blood vessels are all the way in the bottom. Most of them, at least 90%. That's why the people, when they get lung fibrosis in the base of the lung, they do like a lung transplant, even though the top part is fine. But because most of the perfusion blood vessels are on the bottom, so they're not equal. All areas of the lung, all zones of the lung are not vascularized equally. There is extensive vascularization at the bottom. That's why the doctor, when he's listening to your sound, is putting the stethoscope where? At the top or in the bottom of your back? The bottom, because that's where the magic happens. That's where most of the exchange happens. So you gotta take care of the bottom of the lung and ensure there is no fibrosis. With every time you get a flu, there's like millions of alveoli. But every time you get a flu, you lose a couple. So if you're the kind of person that gets flu every winter, I guarantee you by 60 years old, 55 years old, you're gonna be having severe lung problems. So you gotta take care, when it's cold outside, you gotta put on your mask. You gotta stay warm. You gotta take care of it. You don't live in an urban society that, there is a lot of pollutants in industrial system. Yeah.
Well, it's funny that you say that because I have asthma and I notice like if I walk past like a bus, I have trouble.
Me too.
Yeah.
Nobody lives in industrial New York City with all of the gas fueling and all of and especially you take the subway and all of this is very bad. Now you go outside, even outside New York, not even out New York, just outside in New York City is nice, the air is nice. The time moves slowly too. Yes. That's crazy. I took a nap, I woke up, I thought it's 7 p.m. They were like, "Oh, God, it's 2:30. I couldn't believe it. The time, the people are more laid back, easy. They don't have a lot of asthma. You want to be a pulmonologist out in the suburbs, nobody gonna see you. You're not gonna be making any money. That's why the people who make most of the money are here. Because they are pulmonologists in a place that is all polluted. And it's gonna make a lot of respiratory diseases. Yeah, so there's always a trade-off. Lungs are crowded by adjacent organs. They neither fill the entire rib cage nor are they symmetrical. So the right lung is shorter than the left because the liver rise is higher on the right. So it has 3 lobes. Remember that. The right lung has 3 lobes, 2 fissures. Superior lobe, middle lobe, inferior lobe. And then you have a horizontal and oblique fissure that's on the right lung. On the left lung, 1 fissure, the oblique fissure, and 2 lobes, superior and inferior. The right lung is the left lung. Then you have the right lobe of the liver, then the left lobe of the liver. The bronchial tree is a branching system of air tubes in each lung. From the main bronchus to 65,000 terminal bronchioles. There's a main primary bronchi supported by a C-shaped hyaline cartilage ring. The right main bronchus is about 2 to 3 centimeters long, arising from the fork of the trachea. The right bronchus is slightly wider and more vertical than the left. Then we have the lobar bronchi. These are supported by the crest-shaped C cartilages. And lastly is the tertiary bronchi. This lobar bronchi, I asked students, what's the name of the blood vessel, the artery that nourishes and perfuses the lung itself? Remember when we talked about the heart, we said that the heart itself needs to eat also. The heart needs oxygen, it's a muscle. The heart itself needs nutrition and needs metabolic waste to be removed. So it has a whole important circulation known as what? What's the name of the circulation that ensures that the heart itself gets blood? That goes through when the artery is closed, when the aortic valve closed, they open and they go right through the aortic valve. These are the coronary arteries. So now who is like the coronary arteries for the lungs? It can never be a vein because vein is going to the heart. A vein is going to the heart. If you're going to the lung, you're coming from the heart. So that's known as, students say, pulmonary artery. No, the pulmonary artery is the one taking the blood that you need to be oxygenated. The pulmonary artery is taking all the nasty blood to go to the lung to be perfused with oxygen. Good blood to the heart. No, the pulmonary trunk is in the heart. No, but you should. Why? Because you can't say the pulmonary trunk because we seen in the last lecture, the pulmonary trunk is in the heart. The pulmonary trunk is in your heart. It's leaving the blood, leaving the heart through the pulmonary trunk. We're not talking about that. We're talking about after you go beyond the heart. Now you in the lungs. You have two kind of blood going to the lung. You have blood going to the lung for an obvious reason of being perfused, oxygen and carbon dioxide. And you have another set of blood for the lung itself. It needs to live. The lung is tissue, cells. So the lung needs oxygen. The lung needs nutrition. So we say in the heart, we also have two blood that is being pumped and blood that is enriching the heart, feeding the heart itself. And we say that's coronary circulation. The lung doesn't have a circulation, but it does have one organ that's gonna feed the lung. It's gonna bring food. You know the waiter bring you food? The waiter is gonna bring you food, but the waiter itself needs to have lunch too. He needs to have dinner too. Who is the artery that's gonna feed the lung itself? And don't tell me pulmonary artery, because that's the artery bringing the blood for the main job of fixing that's why they call it the pulmonary circulation. Remember? Why they call it pulmonary circulation? Because that's what it is the lower artery. The lower artery. The lower artery. You see? Because it is the one that's gonna give the lobe the blood they need to survive. The lobe. Okay? See, that's the bronchi. That's the trachea, that's the bronchi, and this is the right primary bronchus, and there's the. Okay, now we look in the bronchial tree and we have the ciliated pseudostratified pulmonary epithelium. And we said that we end up with the bronchioles, and then from the bronchioles we go to respiratory bronchioles, and now we're finally heading to the alveoli. That is now where all the respiration takes place. That's the most, so all of the guys were actually, they were delivering, they were just delivering the air, filtering the air, humidifying the air conditioning it. Now you got to the most important part, the alveoli, the respiratory zone. Something wrong with the alveoli, you're finished. Something wrong with your nose, they can fix that. Something wrong with your nasal oral cavity, they can fix that. Something wrong with your pharynx, they can fix that. Something wrong with your trachea, they can fix that. Something wrong with your bronchioles, they can fix all of that. Something wrong with your alveoli, new lung, that's it. Never gonna be damage beyond salvage. You can never fix that. So you gotta be realizing that it's those balloons that they don't just, these are a special type of balloon. They get filled with air and they exchange the air. So that's why they are very important. They have two types of cells in the alveoli. You have the police, you have the squamous type 1 alveolar cells. These are broad cells that allow for rapid gas diffusion. These are the squamous type 1. And then you have, these are the squamous type 1. These are responsible for gas exchange. Then you have the great type 2. These are the ones that secrete the pulmonary surfactant. What's a pulmonary surfactant? You know, water has a very special property known as cohesion. So the water molecules, they hold each other close. That's why an insect can get on the top of the water and walk on top of the water. But if you have alcohol and the insect thing is water, they stay on the top of the alcohol, they did. They die. Why? Because the surface tension, they hold the water molecules, hold each other tightly. That's not good. Why is that? Because if you have water in your alveoli, when you take a deep breath in, they gotta stay inflated. They're not gonna be coiled. We want them to be coiled. That's where the surfactant comes in. So the surfactant is like a lotion. Lotion is gonna be secreted by these type 2. These type 2 great alveolar cell, and the surfactant on the surface of the alveoli is gonna destroy the surface tension. So now they're not gonna be so tightly held, which is good. We want that. Why? We want the alveoli to inflate, deflate, inflate, deflate. We're gonna have elastic recoil. So we don't want surface tension. So that's why we use pulmonary surfactant to reduce surface tension so we can have elastic recoil. Clear? Yeah. Okay. Alveolar macrophage is known as dust cells. These are the most numerous of all cells in the lung. They wander the lumens of the alveoli and the connective tissue. They keep the alveoli free from the debris by phagocytizing dust particles. There's 100 million dust cells that die each day as they ride up the mucociliary escalator. So you see the sacs, the little balloons, and the blood vessels around them. The alveoli, each alveoli is surrounded by a basket of capillaries. So the respiratory membrane is a thin barrier between the alveolar air and blood. So the respiratory membrane is a thin barrier between the alveolar air and the blood. And the respiratory membrane is going to consist of squamous alveolar cells, endothelial cells of blood capillary, and their shared basement membrane. You see, these are the alveolar macrophages. These are scavenging, walking around, destroying and eating all of the microbes. We talked about the pleura. The same way the heart has a visceral pleura and a parietal pleura, so does the lung. It has a visceral pleura and a parietal pleura. Now, between the visceral pleura and the parietal pleura is what? Serous fluid, liquid fluid. The pleural cavity is a potential space between the pleura. Normally, there's no room between the membranes, but they contain a film of slippery pleural fluid. Slippery pleural fluid. You see, the parietal pleura is on the outside, the visceral pleura is on the inside, and between them is that fluid. The mediastinum is the area in the middle, is a septum or a space between two lungs. That's the pleural sac. So in pulmonary ventilation, you have breathing or pulmonary ventilation. It consists of a repetitive cycle of inspiration, inhaling, or expiration, exhaling. The respiratory cycle is a one complete inspiration and expiration. There's a quiet respiration. So while it's at rest, there's effort, it is effortless, and in forced respiration, there is deep and rapid breathing. So we're going to see this in the end of this chapter when we talk about the nervous system. In the nervous system, there is a place known as the brain stem. Please remember that. The brain stem is responsible for a region called as the medulla. You know the medulla oblongata. You know, when I was young, I watched everybody hates Chris. His mother said, I'm gonna hit your medulla oblongata. At the time I was young, I had no idea what it was. Medulla oblongata. I know what that is. That's your brain stem. So the brain stem inside the brain of the medulla oblongata is your breathing center. Now, this breathing center is divided into three regions. One is called dorsal respiratory group. You know what dorsal is. That's the back. Posterior. Posterior respiratory group. And you have frontal or anterior respiratory group. The dorsal respiratory group is in charge of inhalation. Getting air in, and you should know what that means. Getting air in means moving the diaphragm down or up. Down. It means you contract the diaphragm. The diaphragm is contracted. What does that mean to the ribcage intercostal muscle? It's gonna excellent. It's gonna stretch them out. Very good. So the medulla oblongata, dorsal DRG, dorsal respiratory group, makes you inhale. Then there is the ventral or frontal or anterior respiratory group that's gonna make you exhale, which is elastic recoil, doesn't require any effort. It's like rolling down a mountain. The uphill up the mountain is the inhalation. The problem is inhaling, but getting it out is no problem. If you don't have COPD, if you don't have obstructive disease, getting air out is no problem. And the last center is known as the pneumotaxic center. This pneumotaxic center is responsible for the depth of breathing. So sometimes we said, we don't just inhale and exhale. We want to make sure how deeply you inhale, how deeply you exhale based on your blood concentration of oxygen carbon dioxide. So the pneumotaxic center is going to tell the dorsal respiratory inhalation group, don't inhale too much because there is so much carbon dioxide, you're going to hyperventilate. That's why somebody on a treadmill going, but you breathing all the way in, breathing. Why? Because your pneumotaxic center is letting you breathe deeply that you don't have. But the one over there, the one on the treadmill, is gasping a lot of air because your pneumotaxic center is shortening your inhibitory, your inhalation. We gotta see that. This is just about advertisement.
So, like, I know we exhale a lot when we exercise because, like, obviously more oxygen, but it's also because as your muscles are moving, there's waste being built up. Is that big?
Yeah, because there is excessive metabolic weight, lactic acid. Like you said, it's excellently when you said the demand is very high. It is so high that aerobic respiration is not enough. Now we do anaerobic in addition to the aerobic. And one of the problems of anaerobic respiration, we're not bacteria, we're not fungi. They rely on anaerobic respiration. But when we do anaerobic respiration, what's the problem with anaerobic respiration? It remains very bad toxic metabolic waste known as lactic acid. That's why you have a lot of acidosis and you want to shut it out. And we say acid, we convert it to carbonic acid in the red blood cell, we throw it out. Yes.
That is the same reason why we're working on, say, going for like, having emergency sensation, right? That's a accumulation of lactic acid within the muscle. Right?
Yeah. Yeah. Why do you have a lot of accumulation of lactic acid in the muscle?
Your muscles are using that oxygen, and as they continue, and you look from a break, right? Like acid on aerobic condition, right? I guess the lack of oxygen is.
So oxygen, we're using it is not enough. So we at the same time with aerobic respiration, we're doing anaerobic respiration. And the metabolic waste of anaerobic respiration is lactic acid. So it is us. You know, sometimes you're spending money, it's not enough, you borrow money. So that's the issue. So now you burning so much oxygen. Now your body says oxygen not enough. Let's have anaerobic in addition on top. Let's take a load from the bank. So now you do that. Then you the interest is gonna be the lactic acid. Very good. Very good. Okay. The diaphragm, we talked about that. It is the nervous tissue, it is a muscle that gets stimulated to contract. When it contract, when the diaphragm contract, does it move down or up? We said it moves up when it recoil. We said it moves. No, you have to think about it. Moving up is like you're stretching a rubber band. The problem is when you pull it back, but when you let go, it stretches right back. So your diaphragm is a muscle. You get stretched down, and your intercostal muscle gets stretched out. Then they all relax, and air goes out. So exhalation is yo-yo, is elastic recoil. It's inspiration. That's the problem. When does exhalation become the problem? Yeah, that's known as what? Yeah, very good. You got it now. That's obstruction. That's COPD. Is a big umbrella, COPD, but they are different diseases. Emphysema is COPD. You have asthma is also COPD. Yeah, but it is not as bad. And you know, one thing you reminded me when you mentioned the asthma. Asthma is different kinds. Some asthma is genetic. Some asthma is irritant, is because when you got irritated by something. Some asthma is because infection. But the symptoms are the same, and the treatment usually is the same because you have obstruction. Air is not flowing out. Okay? What did you want to say?
I hate asthma.
Yeah, all of them.
I got it up with age. So, like, last year I had like a bad symptom, like that. So that's like, I think it's forcing and getting all the carbonic acid out of my tongue.
Yes. So carbon, we are flushing, shunting, removing all of the carbon. Yeah, good. You had a carbon dioxide.
Right.
Albuterol sulfate and
Oh, yeah.
But it's another one who gave me that's it lasts in one person.
ipratropium bromide. So there's two ones. One is long acting, one is short acting. That one you need to have it all the time. Because if you get an asthma attack, you don't have that one next to you. You're gonna not be able to remove carbon dioxide, and oxygen is not gonna be able to come in. You're gonna have a depletion of oxygen. Your cell, your tissues cannot find a proper amount of oxygen, and then that's gonna cause poisoning. And you're gonna have severe depression of oxygen. Because this oxygen saturation in your blood is gonna drop. You're gonna have hypoxemia. Hypoxemia is when there's a drop of oxygen in the blood, which is different from hypoxia. What's different between hypoxia and hypoxemia? That's hypoxia. Hypoxia is when both of them are a drop in blood, whether hypoxemia or the hypoxia. But hypoxia is when you have a drop in oxygen in a tissue. But hypoxemia is when you have a drop of oxygen in the blood, which is not the same. Now, sometimes you can have enough oxygen in the blood, but because of a blood clot, you cannot get into the tissue. So the tissue has hypoxia even though you have oxygen. Because you cannot get oxygen to the tissue due to a lack.
If you have oxygen, all the tissues are infected.
Yeah, if you have hypoxemia, there is no oxygen at all. But every hypoxemia leads to hypoxia, but not every hypoxia is caused by hypoxemia. Sometimes you can have oxygen, you can get it there. But if you don't have oxygen, you will.
Let's bring the post up somewhere.
Yeah. The pulse oximeter is measuring what? Where? In the blood. Excellent. Because we have another issue, oxygen level in the tissue. We don't measure that with oxygen. We measure with oximeter the oxygen saturation in the blood. So we don't want hypoxemia. Okay, clear? So you see the extracostal muscles and the intercostal muscles. So the intercostal muscles, they are closer to the center. And external, so there's two intercostal muscles. There's internal intercostal muscles, and these are between this cartilage layer here. While the external intercostals, they are on the outside. Internal intercostals get activated when you are exhaling, and external intercostals, they get activated when you are exhaling. So let's now see. So during inhalation, external intercostal muscles move out. This is where the students have the problem. They say inhaling internal intercostal. No, they confuse the name. You know, inhale intercostal. No, inhale external intercostals. So you have two kinds of intercostal muscles. There's external intercostals and internal intercostals. When you're doing inhalation, it's the external intercostals. And when you're doing exhalation, it's the internal intercostals. So this Valsalva maneuver is very important during urination, defecation, vomiting, and childbirth. It's a maneuver that is being done consisting of taking a deep breath, holding it by closing the glottis, and then contracting the abdominal muscles to raise the abdominal pressure and push the organs out. Okay? Now we come to the very important part, and that is your nervous system. We already alluded to that. We said that your nervous system is like the pump. You know, your heart is receiving, remember EKG? Your heart is receiving electrical stimulation to pump, to contract, to pump the blood. Remember? Now, your diaphragm is receiving stimulation. So if you look here, breathing depends on repetitive stimulation of respiratory muscles from the brain. And we'll see if the spinal cord is severed high in the neck. The skeletal muscles acquire nervous stimulation. There's an interaction of multiple respiratory muscles, and that's going to require coordination. The brainstem respiratory centers. You have an automatic unconscious cycle of breathing that is controlled by three pairs of respiratory centers in the reticular formation of the medulla. So the respiratory center network in the medulla, you have your VRG, remember that, ventral respiratory group, and the DRG, dorsal respiratory group. So there's a primary generator of the respiratory rhythm, especially for inhalation, ventral respiratory group, while the dorsal respiratory group modifies the rate and the depth of breathing and receives influences from the external sources. And there's the pontine or the pneumotaxic center. It modifies the rhythm. That is what I refer to as the pneumotaxic center, the pontine respiratory group. It adapts the breathing to special circumstances such as sleep, exercise, vocalization, and emotional responses. So you see, that's the brainstem, and that's the pons, and then you have the dorsal respiratory group and the ventral respiratory group. We discussed already that the hyperventilation is breathing so rapidly to expel carbon dioxide from the body much faster than it's being produced. And as the blood carbon dioxide levels drop, the pH is going to rise, causing the cerebral arteries to constrict. So this reduces cerebral perfusion, which may cause this dizziness or fainting. It can be brought under control by having the person rebreathe this carbon dioxide from a paper bag. If you have this negative effect of hyperventilation. This concept is very central. Is that clear? Hyperventilation is going to remove carbon dioxide. Central chemoreceptors of the brainstem neurons that respond to changes in the pH. We said that there are chemoreceptors. Chemoreceptors chemoreceptors, we said they taste. They taste the blood for what? For carbon dioxide, acidity, and they feedback. So what's the difference? They are the same. Chemoreceptors, central or peripheral, they are the same. They are tasters of blood, and they report carbon dioxide and oxygen. However, they are located in different regions, like the highway police and the city police. They are police, but they're put on different places. Central chemoreceptors are found in the brain stem, and they measure the carbon dioxide level of the cerebrospinal fluid, while the peripheral chemoreceptors are located in the carotid and aortic bodies of the large arteries above the heart. Central and peripheral input to the respiratory centers. So stretch receptors are found in the smooth muscles of the bronchi and bronchioles and in the visceral pleural. They respond to inflation of the lungs. You need to know that, the Hearing-Brewer reflex. What's the Hearing-Brewer reflex? What's the Hearing-Brewer reflex? You know, when we were young, they tell us the story of the fable, the frog. You know, the frog said to the other frogs, I saw a bull. They said, how big? The frog said, so big. As big as that? And then they said, no, it wasn't that big. So the frog kept going, and bigger until it burst. But anyways, the fable says, don't try to be something that you're not. This is the Hearing-Brewer reflex. The Hearing-Brewer reflex is going to stop you from overstretching your lung like the frog and bursting. So the Hearing-Brewer, it's a reflex, meaning that it's going to bounce back. You can stretch your lungs, then you're gonna stop, is you're gonna be forcibly stopped from overstretching your lungs. That's the hearing burr reflex. Is that clear? You guys heard of this frog story? No? The irritant receptors. These are nerve endings and with the epithelial cells of the airway. If there's chemical fume, cold air, dust, dander, pollen, they're going to be irritated, cause a contraction, and cause these the bronchoconstriction. That's gonna tell you where do we find the, so where do we say that the central chemoreceptors are found? Central chemoreceptors are found where? Yeah, brain stem. Very good. The brain is a very big place. There's the cerebrum, the cerebral cortex, the hemispheres, the ventricles, the brain stem. So it's in the brain stem, in the medulla. So they're going to measure carbon dioxide and oxygen content and the pH of the blood. But those one are peripheral, those are not central. So the peripheral chemoreceptors are found in the brain, while the peripheral are found where? In the aortic body, in the carotid body, and aortic bodies. Very good. Voluntary control of breathing. So voluntary control of breathing originates in the motor cortex or the frontal lobe of the cerebrum. There are limits to voluntary control. So there is a so breathing is involuntary. You don't say, let me remember to breathe, let me remember breathing. It just happens spontaneously. But does that mean you cannot voluntarily control your breathing? You can, to a certain amount. If your breathing goes out of control, you're not breathing as fast as you should, and then carbon dioxide is building up, what's going to happen? You're going to end up in this reflex. Your involuntary is going to kick in. You know, when you are in a driver's car, you know, student driver, if you make a mistake, the driver is going to correct that mistake that you're doing. So you can breathe voluntarily, but if you're not doing it swiftly, fine, then your involuntary system is going to kick in. Pressure resistance and airflow. So the same way we had pressure resistance to blood, we're going to get pressure resistance to airflow also. So we talked about Boyle's law. We said that at constant temperature, if you miss this part, you're going to get it wrong. You cannot say pressure and volume are the opposite. Only at constant temperature. So if the lung volume increases, their internal pressure, intrapulmonary pressure is going to fall. And air is going to move into the lungs. And if the lung volume decreases, intrapulmonary pressure is gonna rise. You see, they are going to equal each other as long as the temperature is constant. And we said, what is this cycle showing you? It's showing you that during inhalation, you pull out. The ribs are going to be moving outside. So that's going to cause the volume here to increase or decrease. Look at the arrows. The arrows are pointing out, out, out. So this all space is going to increase or decrease? Increase. But here, when they're moving in, this place is going to increase or decrease? So is this here where my mouse is? Inhalation or exhalation? Inhalation. Is that inhalation or exhalation? So the passive process achieved mainly by elastic recoil of the thoracic cage. We discussed that. We said that the passive process is achieved mainly by the elastic recoil of the thoracic cage. There's forced breathing. In the forced breathing, you have accessory muscles that raise the intrapulmonary pressure as high as plus 40 centimeters. Now, some diseases you need to be concerned with, like pneumothorax. Pneumothorax is when there's a puncture or a hole in the pleural cavity. You know your pleural cavity. Visceral pleura, parietal pleura around your lung, and there's water between them. There's serous fluid, liquid between them. If there's a hole, air is going to flow in there. And the thoracic wall is going to get punctured. And this the loss of negative intrapleural pressure allows the lungs to recoil and collapse. In atelectasis, there's a collapse of part or all of the lung.
The chest.
Chest tube? I'm not familiar with that. Oh, I see. That's for ascites, to remove like accumulation of water in the pleural cavity. Oh, I see. That's like an aspiration. Like they aspirate and remove any fluid in your peritoneal cavity. Sometimes if you have edema, they put it in your abdominal region and remove all of the fluids and the water from there. So that's like a suction tube. Oh yeah, like a suction tube. So pneumothorax is when there's a hole due to an accident, your rib cage broke, cut your pleural cavity in your lung, and then all the water starts leaking out. So that is gonna cause a disturbance in the pressure, because if it punctured the lung, air is not gonna flow in. So that's gonna be a severe problem. What is atelectasis? Atelectasis is a collapse of part of the lung. Why is that? Because the alveoli have collapsed. Why do the alveoli collapse? Because they lost the elastic recoil. So it's not like emphysema. Atelectasis is like the opposite of emphysema. Emphysema is when you're too stretched, you can't relax. Atelectasis is when you're too relaxed, you can't stretch. So the same way in the blood vessel, we said that the diameter of the blood vessel is important to get the air, to get the blood flowing through the vessel. Do you guys remember that? When the blood vessel dilates, more blood flows. What happens to the resistance? Resistance goes down. Very good. Same way with the airway. If you have asthma, your airway constricts, and what happens to the resistance? Increases. But when you take the albuterol puff, it's gonna relax your airway, getting air to flow in. So the pulmonary compliance, what's compliance? That's the elastic recoil. The ability of the lung, like a balloon, to stretch out, expand, and then relax again. So degenerative lung diseases like smoking and scar tissue and fibrosis, that affects the elastic recoil with which the lung can stretch. The extensibility is the lung extensible. The expansibility is the lung expansible. That is the compliance. Meaning, is it compliant? Does it work? Does it expand? Over the years, as you get older, your lung is not going to be as compliant. And that is because degenerative diseases. And one of the reasons, we talked about that, the surface tension and the water film inside the alveoli. That's why we see this surfactant by the great alveolar type 2 cells. That's gonna relax and reduce the surface tension between all the water molecules huddling together. Infant respiratory distress syndrome. That's very important. You need to know that. This disease is for babies that they cannot secrete the artificial surfactant. They cannot secrete it. So they get lubricant, they get artificially made surfactant that helps them stretch their lungs. Is that clear? So the alveolar like this particular type of surfactant, it is usually taken by like an aspiration. It's taken inside. It's given to them inside the lung, like an endotracheal tube. So they use an intubation to inject this fluid inside their lungs. And that's gonna make, but you need to know, how does it work? So how does the surfactant work?
It's like lubricates the areas, right? So this is what they're not for.
It doesn't lubricate the layers. The layers are around the lung. It lubricates around the alveoli, the bubbles, the sacs, and it helps them to have an elastic recoil. Stretch, relax. Stretch, relax. Now we're going to get to a very important concept, and that is the dead space. What's a dead space? A dead space is a place in your respiratory system where there is no exchange of oxygen. Like the alveoli is a living space because there's an exchange of oxygen and carbon dioxide between the alveoli and the capillaries. Excellent. But in the nose, is there exchange? That's a dead space. That's an anatomical dead space. In a trachea, there's only conduction. Is there exchange? That's a dead space. In the pharynx and the larynx, is there exchange of air? That's a dead space. The conducting zone is, oh yes, excellent. The conducting zone, all of them are the dead space. Very good. The physiological or total dead space is the sum of the anatomic dead space and any pathological or alveolar dead space. The spirometer is a device that recaptures the breathing. This is very important. So let's do this on the board. Okay. Oops. Cool. Let's say this is a neutral 0, 1. This is 0, 1. When you're breathing normally, over this side is positive, and this side is negative. If you're breathing normally, Air come in, air coming back. So you're gaining 500 milliliters of air into your lung, plus, right? Air going into your lung. You're gaining air. You're not losing air. Are you losing air? No. So you're gaining 500 milliliters. You inhale. And then when you exhale, you lose the 500 again. 500 milliliters. So 500 milliliters gain, 500 milliliters lost. That's called tidal volume. That is your tidal volume, TV. That is your tidal volume. What is the tidal volume? The tidal volume is the 500 milliliters of air that's going in when you're inhaling and going out when you're exhaling. That clear? We clear? Is that the most amount of air that can go in? Okay, so the extra amount of air that you can go beyond your total volume, even more, 3,000 milliliters more. 3,000 milliliters more. I forgot what Mark was saying. Unbelievable.
Wait, TV stands for tidal or total?
Tidal. It's like a tide, you know, the beach, it goes up and back. You know, what do you call that when the water go up and
The tide, yeah.
tide? In my language, you have two words. Yeah, we have two words when it goes up and one word when it comes back. So that's why I thought maybe in English there's two. Yeah, so this tide. Yeah, tide. Tide turning.
Are you talking about in your language?
Yeah, in my language, there's two words. When the water go up, there is a word for that. When the water go back, there's a word. My language is very detailed. There's one word for everything. Your cousin from your mom's side has a name. Your cousin from your dad's side has a name. Your uncle, maternal uncle has a name. Your paternal uncle has a name. So we don't just say uncle, and it could be both. From your mom brother or your dad brother. Both are uncles, right? We have two different names for those. But anyway, Arabic.
Arabic? What, like Saudi Arabia?
Yeah, that's my language. We have two. We have one language. It's very specific. No ambiguity. I'm from Sudan. Yeah. So there's a tidal vol. So the tidal volume is like the water going in and going out. Water coming in. There's no marker, and I already asked for a marker. They gave it to me. So now they're gonna fire them. Anyway, so water goes back, but not water, air. Air going in, air going out, that's your tidal volume. Now, when you go to a spirometry, the doctor will say, now, take as high as much air in. That's about 3,000 milliliters now. That's called inspiratory reserve volume, IRV. Inspiratory reserve volume. That's the extra amount you get. Remember, not including your tidal volume, on top of the tidal volume. That is your inspiratory reserve volume. If you want to combine both, is there a word for that? If you want to combine both, tidal volume in and inspiratory reserve volume, is there a word for that? Yes, it's called inspiratory capacity. Inspiratory capacity is when you combine TV plus IRV, you get IC, inspiratory capacity. Inspiratory capacity. Clear? So you have two kinds of tidal. Don't forget, you have two kinds of tidal volume. Tidal volume in, tidal volume out. If you add air in, then on top of that, some more, that's inspiratory reserve volume. You combine both, that's inspiratory capacity. Now let's go to the expiratory reserve volume. If you exhale 500, that's expiratory tidal volume. That's tidal volume. If you exhale even more, you can't do that. You guys have to listen. The same way you take as much air as possible in. You can get as much air as possible out. Yes. You get it all the way out. So the same way we had inspiratory reserve volume, now we're gonna have expiratory reserve volume. Expiratory reserve volume. What is expiratory reserve volume? That's the maximum amount of air you can get out on top of the tidal volume. In the same way, when we combine inspiratory tidal volume plus inspiratory reserve volume, we got inspiratory capacity. What do you think this tidal volume, expiratory tidal volume plus expiratory reserve volume is gonna be called? Expiratory C, not EV, EC, expiratory capacity. Because that one is inspiratory capacity. That's expiratory capacity. Then they realize that there is an amount of air in your lung. No matter how much you're trying to get air out, it's not going out. No matter even you're dead, still air there. So do you see the jar model that we saw earlier? When you relax the diaphragm, did all the air get out the balloons? They were still a little fluffy, right? They were still a little, had some air on them. That's called residual volume. Residual volume. Residual volume. That's the volume that resides in the lung. It's never getting out. No matter how hard you push. Good luck. It's never getting out. It's not getting out, but it's still there. That's called residual volume. Now, if you want to add all of these volumes together, that's gonna give you total lung capacity. All of them. On both sides. Yeah, everything. That's the capacity of your lung. So now let's look at them in more detail. So when we look in more detail, it's gonna make more sense. Oh boy. Oh. Okay. A spirometer is a device that recaptured the expired breath and records variables. Tidal volume, we did that. That's the amount of air inhaled or exhaled. Inspiratory reserve volume, 3,000, we did that. Expiratory reserve volume, 1,200 milliliters. See, that's the spirometer. So if you look here, this figure, this is what I was trying to draw. You begin from 2,500. That's the amount of air that is in your lungs. You gain 500 more, you go up to 3,000, you lose 500, you go down to 2,500. You go up to 3,000, you lose 2,500. That is tidal volume. If the doctor says now take as much breath in as possible, and they take as much breath in as possible, that's gonna cause expiratory reserve volume. And then you have inspiratory reserve volume, and that's gonna go all the way up. That's the extra amount of air you can get inside your lung. But please look at the capacity. The capacity is always the sum of two volumes. So here the vital capacity is the sum of the inspiratory reserve volume, your tidal volume, in addition to the, where does the arrow end? To the expiratory reserve volume. That's the vital capacity. We said that in down here is an amount of air you're never getting out. Good luck. What do we call that? Residual volume. And there is the functional residual capacity, and that's the sum of the residual volume plus the expiratory reserve volume. Then there's the inspiratory capacity, and then there's the total lung capacity, which is the sum of all of them. Okay? Okay, so the restrictive diseases are different from obstructive diseases. We said obstructive, you can't get air out. Restrictive, you can get air in. Very good. So they limit the amount to which the lungs can be inflated, and a disease that produces pulmonary fibrosis. That fibrosis, you can't get air in. And an example of that is tuberculosis and what else? Tuberculosis and black lung disease. Obstructive disorders, you can get air out, like emphysema, chronic bronchitis, asthma. So how do you diagnose these diseases? Is by a ratio. FEV over FVC, FEV1 over FVC. So the forced expiratory volume in the first second. Normally, when I tell you breathe out, they have a timer. Healthy people, normal people, on the first second, they should be able to get out from 75 to 85% of the air in their lungs. If 1 second passes and you get less than 75% of the air to 85% of the out, it means you have obstructive disease because you can't get air out. You got to know the law. This is the law. The law says, the doctor will tell you, do a forced expiratory volume, which means blow out as much air as possible. While you're doing that, all the air going out, what is the doctor doing in the office? Looking for all the amount of air that got out in the first second. If 75 to 85% of your air got out in the first second, you're healthy. If less than 75, I don't care, 74, if less than 75 gets out in the first second, you have obstructive disease. Eupnea is a relaxed, quiet breathing. You see, eupnea. Apnea is temporary loss of breathing, like sleep apnea when you're asleep. Dyspnea is labored gasping air, or there's shortness of breath. Hyperpnea is when there's an increased rate and depth of breathing in response to exercise, pain, or other conditions. Hyperventilation is when there's increased pulmonary ventilation in excess of the metabolic demand. Hypoventilation is when there is reduced pulmonary ventilation, and cosmal respiration is when there is deep, rapid breathing. It means that there is acidosis. Who gets cosmal respiration? People who have diabetic ketoacidosis. Diabetic ketoacidosis. You must understand that air is 78%. Air is 78% nitrogen, 20% oxygen, 0.04% carbon dioxide. It's like a salad. If you have a salad that is 80% tomatoes, 20% green peppers, and stuff like that. So, and you weigh out this salad, how much is it gonna weigh? Obviously, the tomato is gonna weigh the most, followed by the green peppers. Same thing, the air is majorly nitrogen. So that means the pressure of nitrogen is going to equal to 78% of the pressure of gas that's in the air. So that means this is the law of partial pressures. So for example, if you have in the school, 80% students want to become medical assistant, 20% want to become RN. If you choose random 10 people, most likely 8 of them are going to be medical assistant, 2 are going to be, because that's the partial quota, that's the ratio. So same thing, air is going to be represented according to its percentage in the air. If 20% in the air, if there's an amount of air in our lung, 20% is going to be oxygen, because 20% of oxygen was in the air. Is that clear? If 80% was nitrogen, then in the air, then our lungs are going to have 80% nitrogen also. Because the ratio is going to be conserved. On the outside, so we diffuse from the atmosphere into our lung, keeping the ratio conserved and preserved. Okay? Dalton law. The total pressure is the sum of the contributors. Remember the salad? Depends on how much you're putting in. So the partial pressure of nitrogen, since nitrogen is 78%, so you have to know that the atmospheric pressure is 760. Are you sure? Does that make sense? What's the atmospheric pressure? 760. But I know that 78.6 of my air is nitrogen. So what is the partial pressure of nitrogen? Is 78.6 times the 760. So nitrogen is 597. Same thing. Oxygen is 20%. So 20% of the atmospheric pressure is 159. That's the partial pressure of oxygen. So that shows you the oxygen, the nitrogen, argon, water, carbon dioxide, and air. That shows you the Dalton's law of partial pressures. So the swapping of oxygen and carbon dioxide across the respiratory membrane. So air in the alveolus is in contact with a film of water covering the alveolar epithelium. So for oxygen to get into the blood, it must dissolve in the water and pass through the respiratory membrane, separating the air from the bloodstream. So for carbon dioxide to leave the blood, it must pass the other way and then diffuse out of the water into the alveolar. Henry's law says that at the air-water interface, for a given temperature, the amount of gas that dissolves in water is determined by its solubility in water and its partial pressure in the air. Its solubility in water and partial pressure in the air. So the greater the partial pressure of oxygen in the alveolar air, the more oxygen the blood is going to pick up. So since the blood is arriving at the alveolus, has a higher partial pressure of carbon dioxide than air, it's going to release carbon dioxide. So that shows you the more of a particular element do you have in the air, the more it's going to diffuse. So Henry's law says that at the air-water interface, for a given temperature, the amount of gas that dissolves in the water is determined by its solubility in water and its partial pressure. So just because you have a high partial pressure in air, it doesn't mean you're going to dissolve in the blood, because we also need your solubility. Are you going to be able to dissolve in the blood or not? Okay. So now this is talking about the pressure gradient. We describe that the more air is going to flow into the lungs if and only if the partial pressure for a particular gas is higher in the lung, it's higher in the atmosphere than it is in the lungs. So you see here, this diagram is very important because it shows you that when you inspire air, when you bring air in, so air is going to be inspired and being brought into this particular trachea. Air is going to flow in. You see what's the partial pressure for oxygen in the air. Look at the numbers. This is very important because that shows you we obey the law of the biophysics. In the air, the partial pressure of oxygen is 159. In the lung, partial pressure is 104. What is more, 159 or 104? So now air moves into the lung. Not only that, we go to the heart. What's the partial pressure of oxygen in the heart? 59. So air flows in from 159 to the lung 104 to the heart 95. Then the tissue. What's the partial pressure for oxygen in tissue? 40. So we went from 159 to 104 to 95 to 40. So we go down pressure gradient. And the carbon dioxide. Carbon dioxide in the tissue is how much? 46. You go to the heart, and then it's 46, and then the air is 32. So carbon dioxide flows out from an area of a high carbon dioxide to an area of the lowest carbon dioxide. So carbon dioxide is 20 times as soluble as oxygen. And the pulmonary alveoli in the health and disease. So the membrane thickness. So they presents little obstacle to diffusion, and there's pulmonary edema in the left in left ventricular failure, it causes edema and thickening of the respiratory membrane, and there's pneumonia, which causes thickening of the respiratory membrane. And when the membrane is thicker, the gases have farther to travel between blood and the air and cannot equilibrate fast enough to keep up with blood flow. Gas transport. So the process of carrying gases from the alveoli to the systemic tissues and vice versa. So oxygen transport is going to be 98.5% bound to hemoglobin and 1.5% dissolved in the plasma. Now, we need to learn lastly about hemoglobin. How does hemoglobin work? Hemoglobin is the main carrier of oxygen and carbon dioxide in the blood. But you must understand that we said already in that room that there is an uptown trip and a downtown trip. You cannot have two people traveling in the same trip and they have different destinations. That's why you cannot have oxygen and carbon dioxide coexisting in the red blood cell. Because if you have a downtown trip from the lung to the tissue, you're carrying oxygen. If you have an uptown trip from the tissue to the lung, you carry carbon dioxide. So now we're gonna see how does that happen. There are 4 molecules of oxygen in the red blood cell, and each one of them is gonna bind to an iron heme group in the core of that red blood cell. So carbon dioxide is gonna be, you see this is carbonic acid. So carbon dioxide is gonna react with water to give you H2CO3. Students confuse those. HCO3 is bicarbonate. Students look at the number 2 here and they say, oh, 2 bicarbonate. No, that's not bicarbonate. This is bicarbonate. The one that doesn't have a 2 on it. The one that has a 2 on it, that's the carbonic acid. Carbonic acid is made from who? From carbon dioxide and water. And that's going to give us this. This form is the one that is going to be, this carbonic acid is the form that is going to be carried in the red blood cell. It's called carbaminohemoglobin. Carbon monoxide is going to compete with oxygen for oxygen binding sites. It is colorless and odorless. This is insane. It's crazy. Because carbon monoxide, you can breathe carbon monoxide and you're dying, and you're not even aware of it because it's odorless. It's not like nitric oxide. Remember earlier I said nitric oxide is the one that you tend to breathe and you realize it's very noxious, so you move out of the area. Like the one that comes out your gas. Actually, your oven, the one that comes, that one, that's actually odorless too. But they added nitric oxide to it so that if it leaks out, you can sense it and go close it. Otherwise, you're gonna all die. And you're gonna wake up dead. You don't even know it. So carbon monoxide compete with oxygen over a ride in the red blood cell, in the hemoglobin. If you put hemoglobin in the middle, oxygen and carbon monoxide, guess who's gonna bind faster? Carbon monoxide. So it displaces oxygen and binds in place of it. Systemic gas exchange. You have the unloading of oxygen and the loading of carbon dioxide. So this figure here is very important because it shows you this is the tissue. The tissue that, remember earlier we said is suffocating. Oxygen is not enough. Now we are borrowing anaerobic respiration. So there's so much carbon dioxide. This carbon dioxide, 7% of it is actually carbon dioxide in blood. But the vast majority, 70%, is going to bind to water. And please remember this enzyme, CAH, C-H-C-A-H. What does CAH do? CAH is carbonic anhydrase. Carbonic anhydrase. Carbonic anhydrase is going to bind carbon dioxide to water to give you carbonic acid. To give you carbonic acid. So that shows you how does carbon dioxide exist in the blood. 7% exists as actual carbon dioxide. Only 7%. 23% are bound as carbon dioxide bound to hemoglobin, carbaminohemoglobin. But the vast majority is carbon dioxide that has been converted by carbonic anhydrase into carbonic acid. When carbonic acid is made, it's going to disintegrate into, you see how the carbonic acid gives us acid, H plus? Gonna give us H plus, and it's gonna give us this bicarbonate. Bicarbonate is gonna be shuttled out into the blood so we can breathe it out. And in place of it, chloride is gonna come back in. That's why we call it the chloride shift, to keep the neutrality. So this is an antiport. Okay, and this shows us and then this acid here, this hydrogen proton is gonna bind to the oxygen in the red blood cell, and it's all going to be shuttled and brought out. Clear. 1.5% of oxygen is found dissolved in gas, and 98% is going to be inside the red blood cell. The last thing we haven't talked about is the Bohr and how we talked about the acidosis and alkalosis, but numerically you diagnose them if the blood has to be between 7.35 to 7.45. If you go below 7.35, that is known as acidosis. If you go above 7.45, that is known as alkalosis. If the partial pressure for carbon dioxide is below 37, that is known as hypocapnia. Above carbon dioxide, above 43, that is known as hypercapnia. Now what's remaining is the Bohr and Haldane effect. That's the only thing we didn't talk about. Bohr and Haldane effect. Talked about cyanosis, hypoxia and hypoxemia. We discussed those. Now, where is the Bohr and Haldane effect? What? They don't put them here? No way. Where's Bohr and Haldane effect? Uh-oh. Okay, diseases, we talked about the hypoxias. And cyanosis is when there's like a contusion, abrasion, or some sort of a problem where blood is not perfused. So you have deoxygenated blood. So after a contusion or a bruise, it always bluish discoloration because the blood is not perfused with oxygen. And the pulmonary COPD, we discussed those, obstruction. An example of those are the asthmas, the chronic bronchitis, and the emphysemas. And lung cancer, an example of that is the squamous lung carcinoma and the adenocarcinomas. Okay. Before we go, I want to quickly discuss the Bohr and Haldane effect. Those are very important. Okay, the Bohr effect says what? The Bohr effect says that your hemoglobin.
Future fighting.
Okay, the Bohr effect says that if you have oxygen, partial pressure, meaning how much oxygen is available, that's tissue oxygen partial pressure. And that is oxygen saturation in hemoglobin. So the law here is blue, meaning if the tissue is 20% saturated with oxygen, meaning it doesn't have 80%. It lost 80, only has 20. What will the hemoglobin do? The hemoglobin is going to unload 80 and it's going to keep 20 back. So the more you need oxygen, the more hemoglobin is going to give you oxygen. Bohr effect shows that if there was a problem, like you're exercising, or it's too hot outside, or your pH is too low, the graph is going to shift right and down. What does shift right and down mean? It means that it's going to give you oxygen now even more than it would before, because now you're suffering from pH that is low, temperature that is high. diphosphoglycerate or biphosphoglycerate, meaning metabolic toxic waste. So this Bohr effect is showing you the accommodating, the adaptive ability of hemoglobin. Meaning that if you need oxygen at rest, it will give you. But if you're exercising, you're suffocating, it'll give you now even more because now you're under stress. So Bohr effect is the effect that hemoglobin will undergo to compensate, to accommodate, to adapt to stress like low pH, metabolic waste, or high temperature. Clear? Haldane. What is the Haldane effect? Haldane effect is the same thing like Bohr effect, but it is for who? Haldane effect is the same effect, but is for who? It's for carbon dioxide. Meaning if you have a lot of carbon dioxide in your blood, your hemoglobin is going to be uptaking much more than it would at normal situation. So if hemoglobin is going to go to your respiratory tissue and take carbon dioxide, if you're now under temperature, heat, metabolic waste, it would take even more than it usually does to accommodate and in order to compensate for this trend that you're going through. So both of them, Bohr effect and Haldane effect, they are compensatory, adaptive effects. Compensatory, adaptive effects that are for acclimatization. Clear? Okay. All right. So now we will begin virtual labs, and we will relocate to the lab to look